First, good evening, everyone, and thank you, Nick, for that introduction. Just very happy to have an opportunity to spend some time with you today and talk with you about some of the work in our office in DC, and really the role of health IT in this era of delivery system reform. As I was preparing, it occurred to me that the goals of this assembly align pretty closely with the work that we do at ONC. In particular, really this idea of developing relationships and collaborating with your peers and working together to tackle today's business challenges in particular. In our case, we're sort of focused particularly on information technology, but those three activities are pretty close to at least how I view our role in the federal system. And further, the Alliance's mission crystallizes for me the importance of coming together as leaders, really, to further develop an ecosystem that's focused on innovation and knowledge. So tonight I'd like to do three things. First, I'm going to give you just a little bit of a story of how I first got interested in health information technology. The second thing is really to give you some background on the work that we do at the Office of the National Coordinator and some progress that we've made. And then for the last little bit of the discussion, I want to sketch out what we at ONC see as the future of health IT and why I think you in particular play a critical role. So first, back in the time machine. I'm gonna take you back a couple of decades when I found my sort of passion about health IT in particular. It's either me or my son, one of the two. That's what I got at one of the other sessions that I gave. But 22 years ago, I was a captain at the time in the U.S. Army, and I was stationed at Fort Belvoir, but I'd gotten deployed to Haiti. It's with the 28th Combat Support Hospital, and that's the group that supports the 18th Airborne Corps. And while I was in Port-au-Prince, we had a guy come into the emergency department, about a 20-ish-year-old, sort of superbly fit 82nd Airborne trooper. That's all they have, you know. And he had a fever, and he had this weird rash, and really he got on our doorstep with that symptom complex, and we couldn't figure out what he had. We knew he was probably too sick to serve, but we didn't really know what he had. So we had a commander, Virgil Deal was his name. He was a general surgeon who said, we brought this gizmo from DC with us. Why don't you give it a try? So we literally rolled a Humvee to the side of the Combat Support Hospital's emergency department. And we had this large black telemedicine kind of contraption that we put on top of the Humvee and zeroed in to the network. We communicated with Walter Reed Army Medical Center, some 1,400 miles away. And I had the very first, and actually the last, at least to my knowledge, diagnosis of porphyria that I've ever known. It's a sort of pretty rare, complex skin disease and nervous system disorder. And, there would have been no way that we would have found that out in field. We did the medevac and took him back to stateside. And I just remember thinking at the time that the way that we practice medicine in the future just really won't ever be the same way again. Once you've had access to technology that allows you to significantly improve patient outcomes, you just never want to go back. And why should you? After that experience, my career went on. I was an emergency medicine physician. At the time, I moved in a few leadership roles. I was the president of an emergency medicine and hospitalist medicine group in Charlotte, and I was CMIO for a health system in Louisiana. Took care of about 40% of the population in Louisiana at that time. And I most recently served on the operations side as the president of that health systems medical group. And so I stand before you really with two vantage points. One really is as a physician who was, as up until January of this year, providing care in emergency departments in Louisiana. And two, really as an executive who was responsible for making sure that the balance between the business side of health and healthcare was rightly met. So I'm pretty sympathetic, very sympathetic actually, to the challenge of this balance and the difficulty that entails. So let's talk a little bit about where we are. So we've really made some historic gains in the adoption and use of electronic health records. it's not just hospitals and doctors that are benefiting from this progress. Really, it's individuals and communities all across the country. In fact, last month we just released data from ONC showing that hospitals, more hospitals than ever, are making electronic information available to their patients. Specifically, we now can say that almost all hospitals allow patients to view their information electronically. 9 in 10 hospitals allow patients to view and download their information electronically. And 7 in 10 hospitals allow the trifecta of patients to be able to view, download, and transmit their information electronically. And that's a pretty dramatic increase over a relatively short period of time. In fact, it's a 70% increase in this view and download capability, and a 7-fold increase in this ability to do all three, and that's really just since 2013, when only 10% of hospitals allowed that activity. Another statistic that I like to highlight is now about 40% of hospitals allow patients to do all three of these capabilities. In 2013, just a few years back, no state had more than 40% of their hospitals with all three of the capabilities. And I like to highlight that because it shows we really are making progress throughout the country in some of these areas. In particular, we believe that when individuals get, review, and use and share copies of their electronic health information, they're better able to monitor their chronic problems, make sure their health information is accurate and correct in their records, and they're better able to share that information with others, whether it's for their own personal care or to share with their care delivery system and team that they're working with. And really, this activity is just meant to make sure that we ensure that patient information is available when and where it's needed most for patients to further their care. So if you talk about the work that we do at ONC, really unlocking data and making it available to share across the health system is the core of our work. And in fact, if someone asks me what do we do at ONC, that's the sort of one-word phrase I use if I'm pushed to sort of boil it down. And some of you might be thinking, you know, that's all fine and good and that's great, but if it's so important and so foundational, why isn't it happening at every patient visit and on everyone's PC and everyone's smartphone? And we've spent a lot of time thinking about that question. What is the reason that we've not made the progress that we've wanted to make in this area across the country? And so what we've come up with is really 3 drivers of success. I would say the first one is, in my mind, the most important, and that's this changing the culture around access to information. It includes some things like combating data blocking, which slows the very innovation that can lead to higher quality of care for patients and lower costs. But change of the culture really goes beyond blocking. You know, I hear confusion about HIPAA and discussions about HIPAA almost everywhere I go in this job. Actually, I made it through a whole dinner tonight without that, so I appreciate that, table one. But we've worked with the Office of Civil Rights at HHS to really clarify the individual's legal rights to access their data and to transmit it where they want. And we think it's very important for things like creating apps and other tools to put data to work. And we really actually need your help on it. We need everyone's help on this. And so if you go to our website, healthit.gov/access, there's a lot of information there, and I really appreciate you helping us spread the word in that space. Our number 2 success driver is ensuring that unlocking data is building the business case for information sharing. And I think this is a particularly importance when it comes to a group like this one. So I want to encourage you to continue the work you're doing here at the Assembly and in your businesses by collaborating with each other to develop solutions that transform the way your organizations care for patients. Keeping the patient at the center is a little bit of a tagline these days. We really think it's an important concept, particularly because when we empower patients with their data, they're better able to make more informed decisions about their care and work with your organizations more efficiently and effectively. We see the government's role here is to use Medicare and other payment programs to award the flow of information. And that's a key part of the Delivery System Reform Initiative. We're changing the way that we pay for care to reward quality over quantity. And I'll talk about that a little bit more in some detail. And then finally, number 3, we need to promote the use of common, federally recognized national standards. But unfortunately, we need to be able to speak the same language ultimately, or at least have reliable interpreters in the form of interfaces to really truly unleash the power and potential of the electronic information and the data that now exists in the ecosystem. And occasionally, particularly if I speak before a tech crowd, I get a stone or two thrown at that point. But I think it's an important piece that we do need some coalescing over standards. So at ONC, we think we're at an exciting inflection point. So the way that we actually think about, access, and use health information is changing. And for me, that's very exciting. From where I sit, I can't tell you how often this work on the flow of electronic health information comes up across a wide range of the administration's top initiatives. For example, the President's Precision Medicine Initiative depends on making usable electronic data readily available and easily transferable for patients, providers, and researchers. Or take the cancer moonshot. Vice President Biden recently said the flow of electronic health data is critical to accelerate a cure for cancer. And finally, all of us in the federal government are doing all that we can to combat the opioid crisis. Important information is available to providers today through state prescription drug monitoring programs. One important future step, though, is to ensure that this information from these monitoring programs is available seamlessly to providers. That's within their workflow and within the electronic records that they're working in on a day-to-day basis. At ONC, we're working with our partners to make these state and regional databases interoperable. In my experience using these databases in a couple of states, in particular Louisiana and North Carolina, it's really, in my mind, the most critical step to their ultimate success is this integration into the workflow and the ease of use. That list goes on, but I think it's clear that our work, our foundational work to unlock health data and put it to use is foundational really to each and every one of the initiatives that you see pictured on this slide behind me. So I'd like to take a moment to go back and highlight one of the key drivers of success, the business use case. So as many of you know, we at ONC and really across HHS, we're sort of really focused on this idea of pivoting from quantity to quality, or from volume of treatments and procedures to the value of care that's delivered. And we call that transition delivery system reform. So first, we're changing on the way that we pay doctors so that they can focus on the quality of care they provide, not the quantity of services they offer or order. Next, we're improving care by encouraging better coordination and by prioritizing wellness and preventive services, especially when it comes to improving care for those with chronic conditions. And finally, we're unlocking health data to empower patients and to give doctors the information they need to provide the best possible care for patients when and where it's needed most. These actions to reform the delivery system are key to the user-friendly future of health IT we seek for better care, smarter spending, and healthier people. So that's why really I'm excited to talk with you today about the final quality payment rule that we announced just this Friday. This rule implements the Doc Fix, more formally known as the Medicare Access and Chip Reauthorization Act, or MACRA. And as many of you know, this is a major step in transforming how we pay for care in the country to reward quality. So just as a refresher, MACRA itself was supported by a bipartisan majority in Congress, which isn't always the case, as well as many patient groups and medical associations. And it ended the sustainable growth rate formula. And with it, 13 years of these potential payment cliffs for Medicare doctors and clinicians. And I remember the frustration my colleagues and I felt about the SGR fix each year. And the old system really just didn't work. I mean, when I was president of the medical group in North Carolina, every year we would go through this exercise where we would try to sit around and figure out how would we manage our bottom line with a 20% cut in our Medicare spending every year. And then the second half of that was to sit around and powwow and figure out, if it did come through, who did we know in Congress and who did we know locally that we could talk to leverage that. It was just an awful and exasperating exercise to go through for a private practice medical group. I think with the new program, we're really going to reform Medicare payments, and the number of doctors is a little bit staggering. About 600,000 is the projected number of clinicians across the country that this will directly affect. And I want to emphasize in particular how much the program now relies on the seamless and secure flow of health data. Our collective goal throughout the quality payment program is to support the vision of a simpler approach to technology for providers. It's got two major themes, really: advancing information sharing and then focusing on better outcomes for patients. So now how are we doing that in this program? There are a few things, key things, where this new approach is really different than the status quo of what preceded it. So, number one, we're allowing doctors to select measures on how the technology best suits their practice and their particular care delivery. Number two, we're no longer relying on or allowing the all or none scoring that was a part of the initial meaningful use strategies. Number three, we're dramatically reducing the number of required metrics to report on for health IT, and we're really focusing the ones that remain on this idea of improving the flow of health data and for patients, particularly things like patient access to data and the provider's ability to send and receive electronic information with others in the ecosystem. Number four, we're providing bonus points for doctors and practices that use certified health IT to perform practice improvement coordination activities like population management or care coordination, another one of the conversations we had just a few minutes ago. In particular because improving the coordination of care between teams of doctors and other care deliverers, or monitoring the health of a whole panel of patients or a community, or identifying those who need particular and focused attention, really depends on health IT. And lastly, number five, we're clearly depicting that succeeding in alternate payment models, or APMs, requires the effective use of technology. So in short, the quality payment program recognizes and rewards the fact that health IT is foundational to providing quality care. So, following the admonition of Yogi Berra, if you don't know where you're going, you might end up somewhere else. We'll ask the question, so where does all this work actually lead? So eventually these efforts on information sharing will help us achieve what we've been talking about in terms of a learning health system. When we achieve this, we think the practice of medicine will support public health and research, and that data will provide guidance to patient care in a continuous cycle. We also believe that patient-generated health data will become more and more important for both of those activities in the future. So that means that diagnoses or treatments won't be tailored just to the group that's easiest to enroll in a study, for example. It means precise care, developed for you and delivered for you based on your personal characteristics. This is really the new paradigm of precision medicine, where instead of looking for subsets of patients that represent a population of study, we'll be studying entire groups of patients and using those discoveries to care for individuals based on their specific characteristics. So other digitized industries are already there. So I'm a big Amazon fan, and Amazon's selections for me are personalized based on my history and preferences. So I get a lot of things on woodworking, gadgets, and some gardening products. And I'll tell you, my daughters think it's completely boring, but it works for me. And by the same token, Google does the same kind of tailoring, using analytics to provide advertisements to you based on your history and your interest. And although as a physician, I would really never suggest that medicine is the same as retail sales or internet search, but analyzing data across an entire population to customize the approach is a thread that goes through all of those activities. And it's an important common thread. So providing this type of customized care will help improve the efficiency and effectiveness of care by reducing unnecessary tests. It will also ensure targeted treatments and successful management by clinicians and patients with chronic conditions. So to me, that's one of those things that sounds like both good medicine and good business. So I want to share one more personal anecdote with you. So I have 4 girls, and if you know me for any period of time, you know that I don't ever miss an opportunity to talk about them. That means if you see me at a ball game or Home Depot or any of those things, I'm going to have a word or two to say. And in fact, we have these long halls at ONC, and I have noticed now that sometimes my colleagues sort of duck back into their offices as I come out because I don't want to see the next slides of the Washington kids. But there's part of this story that I think actually is relevant for tonight. And what I'll say is that I had sort of the ultimate proud papa moment in the summer of 2013 when my twin daughters, Kayla and Christine, enrolled at med school. And so the picture behind me is them at UVA at the day of their white coat ceremony. And so I kind of thought I knew what they would be expecting to see at Virginia. I'd been to that school. I knew what it was like to be in med school. And what I want to say is that the highest degree of anxiety was about none of the things that I expected. So there were no tears about biochemistry, no tears about anatomy, no tears about physiology, even no tears about trying to learn Epic's EMR system at UVA. But when they went to outside rotations, where the providers had been documenting on paper, the anxiety was off the charts. And so, look, the thing that I'm trying to say is the next generation of physicians, which includes my daughters, has no concept, and I repeat, no concept of caring for patients without electronic medical records and good technology. They just don't. The only concept they have in this regard is that they expect their technology to continue to improve. They expect that it will make their practice better, and they expect that they'll be able to use that technology to meet the promise of medicine as we move forward. So in closing, I'd really like to thank you again for letting me speak with you for a few minutes this evening, and thanks for the tireless work that you're doing here at the Alliance. I know there's people like you really from all over the country that are really the linchpins for the progress that we have made and the progress that we hope to make in the future. And we'll try to do our part, but really ultimately to achieve the future vision that we're talking about, we need you. So the federal government sort of cannot, should not, and will not do this work alone. We continue to rely on you and your knowledge and your input and your insights to drive us forward. Our technology journey hasn't been perfect, and it won't be perfect. But the great strides we've made in just a few short years, in my mind, is truly remarkable. And I just can't imagine us going back. So thank you again for having me, and enjoy the rest of the conference. Thank you.
Thank you, Dr. Washington.
Yes, sir.
So a couple of questions. So I'm Scott Lundstrom from IDC. I'm going to moderate a little Q&A here, and I thought we'd kick off. So very proud parent, obviously. So father of 4 boys. Unfortunately, my twins are not going to both be doctors. I think I have an engineer and an RN.
Good
All right,
deal.
but they're getting down the path. So and 4 kids is hard. I get that. So hey, you guys just recently published a guide on EHR contracting, and I'm sorry, I should be better prepared here. And your EHR contract guide and a health IT playbook.
Yeah.
So can you talk about that for just a second?
Sure. One of the central tenets is sort of having empowered providers in the purchasing space. And so we, over the last 6 or 8 months, have been working some with some outside companies and some internal resources to put out those 2 tools, the
Right.
Health IT Playbook and the Contract Guide. On the Health IT Playbook, I would say it's kind of the synopsis document that you might get if I was in a health system and I had hired fill-in-the-blank consultant to come in. It has tools in there about figuring out a total cost of ownership. It has portions in that book about helping you figure out what you should, how you should approach your patient outreach and your patient portal and those things. There are some basic blocking and tackling items to help you get the most out of your health IT. And then the model contract, and I have to tell you that it is a guidance for discussing your contract. So we get in a lot of trouble with the federal government if we say that we're giving you a contract. It's not a contract. But the idea behind it is to say, here are some items, particularly around information exchange, that if you're negotiating a contract, you should have some idea about. I cannot tell you how many times when I had my private sector hat on that we would acquire a practice, and particularly doctors in the field with small practices had no idea what the contract negotiating strategy would be. And in some instances, they presume that I bought fill-in-the-blank EHR, it must be the same contract that everyone else in Louisiana, in fact, everyone else in the country has for their contract, with particularly the small providers. So even just broaching the fact that you should ask these items, you should know what happens in the unfortunate event that you need to change vendors, you should know what happens with your data, you should know what an interface costs. And those things should be thought of and negotiated beforehand. So the idea here is that when we're doing this sort of macro push, and we know that we've said we're sort of doubling down on health IT, including for small practices. The idea is to try to give them some tools that they might not otherwise be able to get at. So that plus some of the technical assistance that's being provided from our partners at CMS are sort of a collection of tools that we think are available. So I encourage folks to check out both of those. They're both sort of publicly available.
Great. And then also there's a new expanded oversight and accountability rule.
Yeah.
What can you tell us?
So, okay, this is the one little preamble. So as a guy who was in private practice for a long time and then worked at a health system for a while, I had no idea what it was like to release a rule with a little controversy to it, but now I do. I do. So the enhanced oversight and accountability rules. So the sort of crux of that is we, through the testing program, and the testing program, you might think it's an old and mature program, but it's relatively young. The testing program had a lot of emphasis on the initial activities, and so you get a certified product, it goes out the door. What our physician and hospital colleagues told us pretty soon after is that, what are the checks and balances that you have once this is deployed in the field to know that what was tested in the lab actually is what I purchased and it's working the way that I think it should work. Right. So we've always had essentially an on and off switch for the certification program. So your software is either certified or we decertified you. Right. So we've done a few things with this enhanced oversight. One is to allow some direct review and some review in the field, which is to say something beyond this initial certification. That's number one. The second piece was this relationship that we have with the testing labs. So we've always had a very direct relationship with the certifying bodies, but the actual testing labs and testing scripts, we had a more arm's length relationship. It was really managed by NIST. And so part of this initiative is to pull those back together. And the third, I think is actually maybe the most important, is we don't want the testing or testing results to live in a vacuum. So you could always go and find out if your product was certified or not certified. What you couldn't find out is if your product was in some sort of remediation, if your product was being observed, et cetera. So now hospitals and physicians and other purchasers of health IT will be able to go to the certified health IT product list, the CHAPL is what we call it for short, but they could go to that site and see what the status is. And it's not just a bad status. You could also go and see, I'm getting ready to buy this EHR software that has no bad marks, has never had any review, has never had any been on any improvement plan, et cetera, et cetera. So we think it's the right amount of protection. I'll share one more stat before we switch. I actually, before I joined, I thought I had a pretty deep knowledge of what was existing in the market. I actually did a few handshakes before we started. I sort of either purchased or tried to purchase from some folks in the room. And so I thought I kind of knew what the landscape was. I get to ONC. We have 800 EHR vendors in our certification program. So the idea that that the 4, 5, 10, 8, 12 is the lay of the land is just not the case. So when you get a program that has certified 800 products, right, it does no good, yes sir, it does no good to sort of do this initial certification piece and then not come back and look at it or not know how it's practiced in the field, because of those 800, I can assure you that some folks are not as successful as you would like for them to be as either provider or hospital in that space.
Thank you so much.
Yeah.
So I'm going to ask one more question and then I'll share the mic here. HIPAA enforcement, are we going to see that cranked up in the next year? Are we going to actually start to try to enforce HIPAA, or are we only going to talk about it? Yeah, all right. Next question.
Okay, I can't let that one completely go by. So look, ONC is not the enforcement arm for HIPAA. You probably know that quite well. It's the Office of Civil Rights, HHS Office of Civil Rights. The reason I mentioned HIPAA in the discussion is that more often than not, the discussions about HIPAA are 5 or 10 degrees off from the real issue. So we have a project that we're working on now and would love to have as many folks who are interested in the room. That's around information sharing, and we're asking health systems and vendors to help participate in a MedList project. We're holding some listening sessions on that. But most of what we talk about is the fact that HIPAA indeed does allow you to provide information to patients about their med list, or HIPAA does allow you to provide information to another health system that's either taking care of a patient or that passes on the request for information for a patient. So I think most of the time that we end up with our HIPAA discussions, they end up with those sort of 5 or 10 degrees. The other thing I would just encourage you to do around the HIPAA piece is just look at the folks who've actually gotten fines, and that may be the opposite of the direction that you're going, but I'll just say this from the information flow perspective. Most of the people, when you read what's happened sort of A to B to C, the enforcement arm has been judiciously used, and so I would encourage folks not to use that as a barrier for engaging in either getting information out of EHRs, doing great things with them, providing information to patients. I think that there's still room for all of that. So, yes, sir.
You mentioned the 800 different EHRs that are available now, and as an organization that's trying to integrate our technology in with all 800 EHRs, it has been quite difficult to try to accomplish that. Is there any plans of trying to standardize or give some common platform or some areas that other companies that have things to add that are going to really help organizations improve patient engagement and actually get them into the portal, have that information reside there? Because I think every hospital wants to keep all the information there. They don't want to have something on the outside, but as someone that's on the outside looking in and trying to develop technology that's going to work with all 800, that is incredibly difficult. So I just love to get a sense about what you all are thinking about in that realm.
Yeah, so I'll highlight 2 things. The first is we have been thinking about this for a little while, and so the 2015 EHR certification rule does require every vendor that goes through the process to publish application programming interfaces. It is a step forward in that space, and what it says is that, and I think in some instances it's been larger vendors rather than smaller that have been difficult for folks to get information out of, but you have to be able to.
I think you'll be surprised.
Okay, maybe so. But the push there is to make sure that part of the certification process is that you give those application program interfaces. And for those who don't sort of live in that space every day, the focus, particularly on the rule, is that the security portion and the location of the data in the interrelational database are the sort of 2 pieces that come with the API. Now, in the second half of that, we did publish actually last month the Interoperability Standards Advisory. And so there are a couple ways for us to go on this, but the Standards Advisory was to say, the way it reads is for this type or that type or the other type, sort of literally a list of types of data. It lists the standards, and then it lists attributes of the standards. It says whether the standard is mature. It says whether the standard costs money. It says whether the standard is in wide use. And we thought that that was the right, at least initial series of approaches for folks on the development side. If I'm a person who wants to exchange medications, then I can look and see, is it HL7 version 2 or is it HL7 Fire? Is it widely used? Does it cost me money? Where is it in this industry sweep? The one thing that I have taken from some of the stakeholder sessions and questions like the one that you're bringing up is it time for us to take a little bit of a step forward and sort of give a tip, as it were, or a little note that would say, even though we are not currently in the mode of saying, if you pass this type of information, you must use this standard, should you give a hint as to sort of a policy direction, as it were? Right now, for example, the standards advisory for this year, it's just finished up this year, but it's a 2017 standards advisory, really is pushing HL7 Fire for some applications. Well, it's not quite in as wide a use as some of the other standards, but the standards advisory believes that that's a direction that the country should and will move in the future. So the question is, for those where you might look at the advisory and it would say, this is the one that's in wide use, but this is the one that we think that the industry is going, is there a possibility to signal those? And the last thing I'll say about it, I've gotten rocks thrown both directions, so I want to make sure this piece is completely clear. So I've had people say that ONC, as part of the certification rule, needs to be particularly specific about standards that we test for. And we've also had folks say that if you get any more specific, we're going to chase you down and slash your tires, that we need innovation to sort of burst forward. So I think where we've landed is this concept of the standard advisory. Public-private partnership, the group sort of raises their hand and says what they think the best direction is, and it's a way that we follow or move forward. So thank you. Yes, sir.
So I have a very specific question, and it's a big source of confusion on the development side. So I'm CTO at Stony Brook. I'm also a professor at Stony Brook University, Long Island. And I have some grad students that are about the age of your daughters. And like your daughters, they expect this new world that we know it's coming.
Yeah.
And we have a little Bible that only has 2 commandments. It's FIRE and OAuth 2. So we know we are going to use authentication authorization of FIRE resources,
yep,
scoped in the OAuth 2 call. So
yep,
it's beautiful. It's REST architectures, there is no doubt. But then when we look at the ONC documentation, we find a source of confusion that I hope you can help me understand how I should address this. So on the one hand, we have the old Blue Button initiative, which is patient-facing and would use FIRE. So this would be the more disruptive model that I'm guessing your daughters would sympathize, and my students would as well.
yeah,
On the other hand, we have the smart platforms model coming from the Zach Hannons in Harvard, which, as I understand, EHRs are using as the container for an app store where they would control the use of the API. So we are a little bit thorn, and I'm also aware of the Crucible project where, as I understand, ONC checks on the validity of FIRE endpoints in different organizations and providers. So how does ONC equate these 2 models, the patient-facing Blue Button type model that seems to be disappearing, and the smart platforms model that EHR companies are favoring?
yeah. I might get into a little bit of trouble on the technical aspect of this, but I'll give you a couple of the policy directions on it, and then I can get you in touch with our standards and technology folks. You're describing somewhat of a classic problem in this world that's changing relatively quickly. So you have a situation where Blue Button, at least the initial Blue Button deployments are several steps ahead of where Smart on Fire is. They're a little bit more mature in that space. It still seems to be the direction that many are going, but it's a little bit more mature. And then you have a situation of what should ONC's role be. So the Smart on Fire, part of that came out of the work that was associated with Sync for Science and some of the work out of Harvard that you're mentioning that goes along with the Precision Medicine Initiative. But let me give you the policy framework. We are concerned about the concept of whitelisting applications in a very narrow space. And so I think would be our preference to talk about a trust framework, not for us, but for folks to talk about a trust framework in which the a patient would have unimpeded access through the application of their choice. That's kind of how the OCR guidance is written when they've come back to clarify. On the other hand, I actually do recognize that health systems feel appropriately, number one, they feel appropriately possessive, and they feel that there should be good stewards of the information that they hold on behalf of patients. And so the idea of talking to a CIO or CMIO, and I had that hat for once in my career, and saying that there is not an app store or there isn't a framework that's a trusted framework, and most of those folks would probably point to a vendor framework for this, it becomes a little bit difficult. I want to describe one other quick thing that we're doing that might help frame this. My hope is that we continue to do specific work around applications that are real world and that show this in the field. And so that's one of the reasons we're holding the listening sessions on the medication list work. It allows us to use OAuth. It allows us to use a FHIR framework for the call and response, and it allows us to move to the degree of specificity in the standards developments that are necessary. Having said that, at the end of the day, does it mean that a Smart on FHIR or an application store concept goes away? I don't even know if we have to have that be the case, as much as we have to have some demonstrable use cases that show this works in the field. And then if you want to circle up afterwards, we can get you in touch with our standards folks to talk really about the specifics of the deliverable. But that's the policy framework. You're pointing. Oh, yes, ma'am. Yes,
Hi there. Heard a great talk today, and the talk started with this analogy of a race car, that if we took out the dashboard of that race car, gave it 100 dials, sent it out on the track and let it go, but the data you got from that dashboard was 45 minutes old, that's not such a great race car. And so my question is you got a lot of CMIOs in the room, and we're trying to help populations of health, but we're doing it with data that's very old. What, in your opinion, do we get real-time, close to real-time, Medicare pre-adjudicated claims data so that we can help patients that were in the emergency room yesterday, not 9 months ago, and have an impact in their lives?
Yeah. Since that's CMS data, I can't really give a lot on it, but I will tell you that there is work. There is work that CMS is looking at, particularly for this first quarter, that also uses a FHIR resource and has more of an exposure of data that's closer to real time. It's my opinion, again, from a policy perspective, that they are actually closer to what you've described in philosophy and where they like to go, versus maybe we've been in the past from a thought perspective. I think some of the barriers to that have to do with technical infrastructure. I think that the CMS infrastructure is sort of the old racehorse that runs, but not necessarily sort of the sleek and new. And so there's some constraints based around that. But stay tuned. The CMMI folks and some of the folks at Medicare are actually very interested in the thing that you've described.
We set of time. You good? 1, 2?
Yeah, sure.
Good evening, sir. Thank you for your service. Appreciate it very much. My name is Greg Walton. I work at the El Camino Hospital in Mountain View, California.
Okay.
The subject I'd like to have you address with us is the challenges we face with IT security in healthcare. And I'm very interested in hearing what you believe ONC can do, as well as the rest of the government, to help us face these tremendous cost challenges that we're all trying to replicate the same defenses to protect similar types of data.
So just a couple of thoughts about that. I feel your pain on the security perspective. I think that it's underscored by even more plans to share data, and particularly things like Moonshot and PMI, where you're going to store large bits of data. And I've given the story that if you're going to talk about my CBC or my blood glucose could be anyone's in this room. Particularly, I didn't have any creme brulee or whatever that is there, but it could be close to anyone's in this room. On the other hand, if you're storing my genetic data, it puts another level of security for discussion that we've just not had in the past. So ONC is participating very heavily in the President's Cybersecurity Task Force. That's actually a cross-governmental agency piece. And I think that we were put at the table or asked to sit at the table from an HHS perspective, specifically for the reason that you're sort of underscoring. Number one, the actors are not just local actors. The actors could be international actors. And I'm sure based on your question, you're well aware that it's pretty clear that health information is much more valuable than banking information and other information that folks sometimes don't have nearly the amount of security around. We're sort of behind in that space. And so that task force is coming out with continued improvements and strategies around that very work around how to both secure information at rest and information in movement. And the second thing I'll say is that we just completed a funding announcement for an agency to share security data, and that was between ONC and the preparedness group at HHS. And it underscores the one thing that we saw that was missing in the market, that if one of you folks at the table has a bit of ransomware or hacked, it shouldn't be everyone else to wait in line to hear. Or the only thing that you hear is what you saw on the evening news about it. We should be able to share enough of those specifics in such a way that once we find a solution, that we can all be protected against that particular solution. That's not the case today. It's a 5-year strategy. We expect to have output from that information sharing at the end of this first year. So we're 10 months away from that, but we also know that that's going to be something that needs to live, breathe, and grow as the threats grow and as the sort of needs sort of improve. So we are focused on that particular issue. I think it's a very important issue.
I think we have one last question, and then we're done.
Oh, thank you. Didn't know we'd have time for this. So thank you for what you do. Thank you for the information. Very informative. I will tell you, probably a bit concerning on the provider side, because some of what you talked about in terms of the guidance, and I feel bad maybe for the vendors in the room, tells me I should probably hold and wait before making any future decisions, because the guidance that you talked about is 12 to 24 to 36 months out. So it's not clear where we should be making future investments in IT other than what we've already done for meaningful use and, of course, now for MACRA and MIPS.
You mean guidance on standards?
Guidance on standards.
Yeah. So here's what I would say about that. I think at some point you've got to make the call on what's right for the institution. And there's really only two ways to look at it. We could get out front and plant the flag, or we could lead as a group, and we'll be collectively with the group that's setting the standards. And so, and I get your picture, but we've decided from an administration perspective that in the area of standards, we will follow and work with the standards advisory as opposed to us sort of setting the standards. I think as you look at the maturity curve and as we move further and further down this pathway, I think it would be easier for ONC, for example, to point to a specific standard, test to a standard, and walk away. But I think it's a little early. So even if you talk about fire, which we had sort of a testimonial for back in the back of the room, and that people feel pretty strongly about, there are many of the fire resources that have yet to be built out. And so the framework is there, but there's still work to be done. So as a federal agency, our role in sort of saying that you should use a standard that is not yet mature, even though we think it's the way that folks are going, we were a little reluctant about it. But I do hear your point that it does put people in somewhat of a pickle, but that's kind of where we've decided to come down on it, is sort of the partnership through the advisory. So thanks for the question. So thanks, everyone.